Hello everyone, my name is Larkin Harris and I'll be presenting a critique of dexamethasone in hospitalized patients with COVID-19 preliminary report published in the New England Journal of Medicine on July 17th of 2020. To give a little background about this study, this was performed in the United Kingdom because they noticed that a large percentage of their COVID-19 hospitalizations resulted in fatality. They had a 26 to 37% estimated case fatality rate among hospitalized patients. They knew there were some other drugs, such as remdesivir, that had been shown to decrease recovery time, but there was nothing out there that was shown to improve mortality rates. It was thought that organ damage due to inflammatory processes may be responsible for these deaths, but no one really knew how glucocorticoids would help with that. There was a small trial that showed that methylprednisolone can help improve outcomes, but it was so small it didn't have a whole lot of external validity. This study was a randomized controlled trial evaluating the use of dexamethasone in patients hospitalized with COVID-19 as part of the recovery trial, which stands for Randomized Evaluation of COVID-19 Therapy. This was a study that came across 176 hospitals across the United Kingdom and was supported by several institutes of health. They also evaluated the use of hydroxychloroquine, leponavir, ritonavir, azithromycin, tocilizumab, or convalescent plasma. To discuss the methods of this study, inclusion criteria was anyone hospitalized with clinically suspected or lab-confirmed COVID-19. So this study was interesting in that not all of the patients included had to have confirmed COVID-19. Exclusion criteria was determined by attending physicians. So that was something a little interesting here. The only way you could be excluded was if your physician believed that it could be potentially dangerous to you. As far as randomization goes, they had a 2-to-1 ratio. Every 2 people received the standard of care alone to 1 person who received the standard of care in addition to dexamethasone. There was no blinding performed with the study. Data collection came through the form of hospital records and online follow-up forms after discharge, death, or 28 days after randomization. These questionnaires were looking at adherence to assignment, the receipt of other treatments, duration of admission, etc. The primary outcome of interest in this study was 28-day mortality. So the results of this study showed that of the 6,425 patients, 2,104 received dexamethasone and 4,321 received the normal standard of care treatment. The primary outcome observed was that for patients receiving respiratory support, either mechanical or just oxygen, and for patients who had been in the hospital for longer than 7 days with COVID symptoms, dexamethasone improved their outcomes. For patients that did not fall into these 2 categories, dexamethasone actually was shown to potentially be harmful. So now to get into the critique. The primary exposure of interest was dexamethasone. The primary outcome was all-cause 28-day mortality. This mortality rating here may not be reflective of the actual effect of dexamethasone because patients could have died from things other than COVID-19. This was not accounted for in this study. Another interesting point here is patient censorship and missing data. When I say patient censorship, for those the 28-day data was not collected for, they were simply assumed to survive. So that's another potential area where the data could be skewed, and there was missing data for a few patients. It was a very small percentage, but it was still present. Per population, there were a few different areas where bias could be introduced here. There could have been selection bias as the attending physicians determined the eligibility of each case. Selection bias in that lab-confirmed COVID-19 diagnoses were not required. So patients could have been in this study without COVID-19 and actually skew the results in that they wouldn't actually be studying what they thought they were. The inclusion criteria were also altered mid-study to include only those 18 and older, and about halfway through the study they started including all ages. I just thought this was an interesting thing to note here. After randomization, there were some age discrepancies between the 2 populations. I think there was a few year difference, so there had to be some controlling for that in the data analysis. Another potential issue was in the data collection. All the data was self-reported in a questionnaire after discharge and medical records data, so there could have been recall bias as these patients were filling out their surveys. And there's also no blinding, so both the patients and the physicians knew, which can also affect how the data was reported. Because this is a randomized controlled trial, confounding was minimized, but there was an age adjustment, as I mentioned on the previous slide. Measures of association used included the hazard ratio from a Cox regression, a Kaplan-Meier survival curve, risk ratios, and rate ratios. Measures of statistical stability included p-values and 95% confidence intervals. The primary conclusion of the study may have been affected by information bias in the institutional collection of patient data, selection bias as attending physicians determined the eligibility for the trial, and the lack of blinding, observation bias as patients knew they were being in the experimental group, recall bias as some of the data was self-reported after the fact. Misclassification bias could have occurred if these patients lacked any detailed medical histories, so if they were already on dexamethasone at the time of the trial, or it was also noted in the result discussion section that some of the experimental group patients may not have actually received the dexamethasone, so that up to 5% of that population, so that could have had a significant impact. There were no limitations discussed in the discussion section, which I thought was interesting, something I hadn't really seen in much of the studies I've read. But based on previous studies and the conclusions of this work, I did think that the authors were justified in their findings.